him and the task force members for their hard work. And now I'm going to stop talking and turn it over to him. Thank you.
Awesome. And I want to say thank you to Robert and the Society for having enough faith in me to chair this task force. It's been quite a year, as we can all agree that it's been quite a year. I am excited for tonight's presentation. So for those of you who joined a little bit late, my name is Matthew Lecuyer. I'm a pediatric emergency medicine doc in the district. And my academic passion is the combination of advocacy and health disparities. And so I was approached by Dr. Pineda to chair this task force. And it's been quite, like I said, a great year. And we're going to share some of the results of that task force. And we've got a lot to get through tonight. So let's get started. I wish that I had financial disclosures. I have none. I'm a wee early career attending, so let's put it that way. I wanted to start off with a quick exercise for everybody. I hope you can hear me. These are just a couple of clinical scenarios that I want to have everybody have in their head. So first up would be a patient comes into the office, emergency department, wherever you practice, complaining of back pain. And their history is significant for an allergy to NSAIDs or nonsteroidals and aspirin. They've taken their Tylenol at home and it just isn't cutting it for them. And so they're here in your office requesting pain medication. Patient's put into a single room that has no windows and then waits about 2 hours for a provider to come into the room. I think this is a pretty common clinical scenario that I think a lot of us have experienced, whether it be in emergency medicine or an office-based setting. And I think that when you hear that story, we relate to it and we see a patient in our mind. But if you think for a minute, think to yourself and think if you applied a race or an ethnicity to the patient or a sex or gender identity. And please note that that was not included in the story at all. And there was a reason for that, because my guess is that every one of us really thought about this patient and it was so real to us, those of us who are in clinical medicine, that we saw it and we assigned a patient a race, a gender, social economic status, etc. With that in mind, we have another story that a patient comes to the emergency department, also has a chief complaint of pain. They wait 2 hours for a physician to come to their room. And before that patient, that provider gets to the room, the nurse says, you know, that patient is fine. I know this type. I'm not worried about them. By the way, the patient needs a Spanish interpreter. Again, in this story, in this clinical context, I bet each one of us assigned a sex, gender, et cetera, to this patient. And these assignments that we have assign these scenarios is what we're here to talk about tonight. I used to be a teacher, so I like to think about outlines, and we'll keep coming back to this outline throughout. This is kind of our roadmap for our journey. We're going to start off talking about what unconscious bias actually is and define it, discuss how it relates to the field of medicine as a background for how the task force on unconscious bias in medicine tackled this topic. We'll talk about what we did and our results, and then talk about next steps and open it to some other questions as time allows. So let's start. Defining unconscious bias in less than 20 minutes, and go. So many of us have probably heard this phrase unconscious bias before, but like anything in medicine, it goes by a lot of names. Including implicit bias or implicit prejudice. Those phrases in the academic literature surrounding this topic are all, for the most part, interchangeable, but to make everything simple and consistent tonight, we'll be talking about unconscious bias. I'll try not to slip up, but if I slip up and say implicit bias, it's the same thing. What we're here to really understand tonight, and what's really important, is that these are unconscious. We do not know that we have them. They may not line up with our personal, externally stated beliefs at all. Unlike those overt biases that people may hold, these are not intended to do harm. They're not intended to label an other category, despite that they end up doing that. They are outside of our awareness. But like other biases, they're based on people's characteristics rather than factual data. And it uses those characteristics to draw conclusions. I hope that makes sense to everybody, but if we need to, I like to make things in a bunch of different forms, including list forms. So just a reminder that unconscious bias is outside of our conscious action and outside of our conscious awareness. Not based on facts, but based on stereotyping, and in high stress environments, such as working in an emergency department or trying to see enough patients to keep our office doors open, these unconscious bias are often exacerbated. What unconscious bias is not is what I like to call the well-known isms, things like racism, sexism, ageism, etc. Those are stated with very clear intent and meant to label other, and typically have a negative connotation. Unconscious biases are not inherently bad. They are not uncontrollable, and that's a very important point. And they should be addressed directly as they are recognized. And you might have caught on the first slide that I have my master's in public health. And I want to point out that unconscious bias is not the same thing as population health. I think that's a really important thing to think about, especially when, you know, a lot of us here are interested in advocacy related work. Some people argue that unconscious bias and population health are linked, but we'll talk a little bit more about that in a few slides. One important thing that we need to think about in the back of our head as we talk about unconscious bias is this idea of corrosive disadvantage. Because unconscious bias is inherently linked to characteristics and features of the patient that's presenting or the people in the scenario rather than factual data, it's also linked to this concept of corrosive disadvantage, where there's one characteristic of a group that negatively impacts the subgroup solely based on that first characteristics. So for example, there's an idea that, you know, a Black patient has a worse outcome than a white patient solely because of their race. Then that negative outcome is further exacerbated by the patient's sex or their socioeconomic status. Great. So we've talked a little bit about what unconscious bias is. Remember, it's those biases that we are all have that we're unaware of. But really, how does that apply to our field and to medicine? So when it comes to unconscious bias in medicine, it's just as prevalent in medicine as it is in the general population. And it will impact every aspect of a person's career in medicine, starting with even before medical school to medical school admissions, through medical education, graduate medical education, and can even impact clinical care delivery, though that piece is a little bit controversial still. The ACGME, for those of you who don't know what that is, that's the Accreditation Council for Graduate Medical Education, and the AAMC, which is the American Academy of Medical Colleges. Both of them try to address unconscious bias in both of their respective roles. Like I said, unconscious bias is, medical education is not immune to unconscious bias, both in the admissions decisions and curricula that students experience. And so the AAMC and the ACGME give some guidance. So the AAMC states that education and inclusion must be part of medical education, especially as it pertains to those underrepresented in medicine. They specifically state that. The ACGME states that programs for graduate medical education must be evaluated annually. And in those evaluations, they need to be evaluated on how they're promoting diversity within the workplace as a means to enhance diversity exposure within graduate medical education. When it comes to clinical care delivery, data shows that unconscious bias is exacerbated by external and internal stimuli, such as time, lack of factual information, cognitive overload, and decision fatigue. I think that all of the clinicians here will agree that, starting off fresh in the morning, you don't have as much decision fatigue. And then over the course of the day, you start having more and more decision fatigue as you see more and more patients. And you just in yourself are very exhausted. It's also interesting to note that sleep deprivation also falls within fatigue, and our residents are not immune to that aspect as well. Our minds as humans cannot handle all of these stimuli. And we have developed strategies in order to mitigate all of these stimuli all at once. For those of us that like charts, this is just a reiteration here. Every day we face external stimuli, internal stimuli, and that leads to decision fatigue. We can't just simply stop, right? We keep going 5 hours, 10 hours a day. So again, our brains find ways to mitigate those decisions and help us with the decision fatigue. But, and these can apply to any sort of decision making. So you can get rid of the word clinical and just make it decision making entirely. But we're here to talk about medicine tonight, so I think it's interesting to think about it in the clinical decision-making realm. And really, the pressure point, or the point to really think about when we think about unconscious bias and its impact in medicine, is we think about those mitigating strategies. What are those mitigating strategies that we're using, and are they linked to unconscious bias? So early on in my academic career, really struggled with the idea of how is unconscious bias different than population health? And the way that I now think of them is that unconscious bias and population health are two mitigating strategies that clinicians employ when we're doing clinical decision-making. If our mitigating strategies are rooted in unconscious bias, they are linked to premature closure. They're, again, based on characteristics and not statistical factual data. They are distorted judgments based on those characteristics. And when all of those decisions are made with those pieces, you lean towards the unconscious bias side of this scale. Whereas population health is based in real world statistics. It helps you draw legitimate conclusions and helps you really focus in on how can I help this patient who might belong to a population. And I like real world examples. So I would argue that it is not unconscious bias to ask a member of the LGBTQIA+ community about substance use in your office in the emergency department, because substance use disorder is higher in this population, in this subgroup. That is the real world statistic, and that is a legitimate conclusion to draw from the statistics that we have and the population health that we have. What is not okay and what is unconscious bias is to label the patient in your office who is a member of the LGBTQIA community a substance user because they identify with that subgroup. So there's a subtle distinction there, but I think it is really important to keep in the back of our minds and when we think and talk about unconscious bias. Unconscious bias in medicine has been studied. It is a long-standing phenomenon, and it has been addressed in an academic fashion for many years. I love evidence-based medicine. That's how I was, quote unquote, raised in medicine. So when you look at unconscious bias as a topic, there's many analyses. In 2017, there was a meta-analysis that was performed in order to examine how unconscious bias related to clinical care providers. So this study looked at articles from 2003 to 2013. And what they found in that study, after looking at all 42 articles that existed, is that healthcare professionals score similarly. Hello? Nope. If there's any questions, please feel free to either type them in the chat box, and Robert will happily interrupt me. Healthcare professionals score similarly to the general population when it comes to implicit bias. So there is implicit bias within the general population, and physicians are no different. We are on the same sort of curve as the general population in all of their compiled data. The issue is when that implicit bias affects clinical decision-making, which it was correlated, but as we all remember, in any high school statistics class, correlation does not equal causation. They are not the same thing. It's been implied, but it's never been proven. Another 2017 project points out that unconscious bias is exhibited in pediatrics as well. I am a pediatrician by training first, and so I look at my profession with a critical eye. This study by Johnson et al. Looked specifically at the idea of academic careers, and I will say pediatricians are always happy to volunteer for things, so I think that's why they chose this this group to do this study. But basically, they looked at those who make academic hiring decisions and workplace recruitment and retention. And what they wanted to see is, how does implicit bias affect them? So they did this survey based on the implicit association test, which is a Harvard study tool on unconscious bias. I highly recommend everybody go do it. It's free to do. 93% of the folks that participated in this were included in some role, whether it was in academic recruitment, retention, etc. What they actually found was that there was, on the implicit association test, a slight pro-white, anti-Black bias amongst folks who are making academic decisions and academic hiring and promotion decisions within academic pediatrics. But again, this is correlation. It does not mean causation. So implicit bias or unconscious bias has yet to be proven, not implicated, proven to cause clinical care delivery or academic advancement differences between subgroups. So now that we've thought about, unconscious bias and its role in medicine, that is the lens that the task force used to think about, how do we want to address or study the situation for unconscious bias in medicine in Washington, D.C. at this point in time. For a little bit of background, the Medical Society of D.C. convened this task force in early 2020. We started meeting in February of 2020 after the then President Dr. Pineda and the board approved the creation. We are a group of interested folks in this phenomenon, both clinicians and non-clinicians, people who are involved in medical education or just holistic care in general. And we are founded based on the Institute of Medicine report that bias and prejudice on behalf of medical providers may impact differences in care. Our goals and objectives were to examine the state of unconscious bias in medicine in Washington, D.C. And because we felt very strongly that unconscious bias affects every aspect of a medical career, from medical education onward, we really thought that it was important to look at the state of education and the experience of unconscious bias across your career. So that means for undergraduate medical education, for graduate medical education, and those in independent practice. We did try to get a lot of information from healthcare administrators as well to get an idea about the workplace culture. We didn't have a robust response from healthcare administration, so it gave us a little bit of information, but not as much as we had hoped. So the real question now is, how did we do it? So the study took place here, shockingly enough, in Washington, D.C., which is home to over 11,000 licensed physicians within the district. The task force created a survey tool where responses were collected via a Likert scale to determine how strongly a respondent agreed or disagreed with a given statement. We did include an open-ended response that asked the experience that the respondent had with unconscious bias, either in their education, in their training thus far, or in their career. Questions were also interrelated, so they were thematically lumped, but interrelated, where we basically meaning that medical students and trainees were asked about their current state of education on unconscious bias, whereas independent providers were asked to reflect back on their education and report how strongly they agreed or disagreed that they had education. I hope that makes sense. So survey responses were anonymous. Demographics were collected, including SOGI data, which stands for sexual orientation, gender identity, years in practice, primary practice zip code, race, and ethnicity. We collected, the survey was delivered electronically via SurveyMonkey throughout July 2020 to August 2020, smack dab in what we hope is the middle of this pandemic, where people were at home and looking for things to do besides make sourdough bread, and hopefully respond to our survey. Data was analyzed via both qualitative and quantitative analyses. It was nice that we had a Likert scale to give us a little bit of that quantitative data that we are also comfortable with. But we felt that qualitative data would also be important to examine as well. We received almost 300 responses, which was a small N in comparison to the number of licensed providers there are in the district. However, it still gave us a lot of data. Just some demographics that I think would be important. About half were cisgendered females. Sorry, we had the breakdown there is about 109 medical students, and 21 residents and fellows. Combining that, there was about 130 of those in training from undergraduate to graduate medical education, about 158 independent providers, only 9 administrators responded. Like I said, just over half were cisgendered female, and the majority of respondents were heterosexual. We did want to do a racial ethnicity breakdown, and yes, I know that those all add up to over 100%. We wanted to really know how many races people identified with, and what is represented within the providers in the district. But as you can see, the majority responses were white Caucasian. Some interesting things to note. So we'll start kind of going through this a little bit, and bear with me. Over 70% of those in training, so combining medical students and residents and fellows, stated that they, quote, strongly agreed or agreed, so in the affirmative, that their programs were providing education on unconscious bias, which I think is really exciting, especially as this topic is going to affect the next generation and beyond, and is currently affecting providers. But that contrasts really starkly with about only 40% of those in independent practice who stated that they felt that they strongly agreed or agreed that their education had topics surrounding unconscious bias in medicine. Also, interestingly, only about 21% of independent providers reported that they would strongly agree or agree that they sought out continuing medical education on unconscious bias. So that leads to a little bit of a difference between these groups, those in training and independent providers. A striking 50% of trainees, medical students and residence fellows, reported that they strongly agreed or agreed that they have experienced unconscious bias in their education, which is concerning to me as a medical educator. What was also really interesting to note is that about 70% of independent providers felt that they experienced bias in their clinical practice. So despite a self-reported non-education on the topic, they feel as though they've experienced this phenomenon and that they can recognize it when it happens. Looking only at clinical practice impact of independent providers. So these questions were asked for our independent providers. The first number is the percentage, the number in parentheses is the actual N of responses. When you asked, does it impact my clinical practice? Like 2/3 said that they strongly agreed that unconscious bias impacts their clinical practice. Not that they themselves were impacted or experienced it, but they feel like it impacts their personal clinical practice. They also report that they've observed it in clinical practice at around the same percentage. And again, there is that 70% that say that they themselves have experienced it. So that is telling. Whereas previous work in this arena has been unable to show that unconscious bias impacts clinical care delivery. This one question here says that independent providers are reporting that they strongly agree or agree. 2/3 of the respondents that were independent providers, of 158 folks, say that unconscious bias is impacting their clinical practice. When asked trainees, those in training, medical students and residence fellows, if they were concerned that unconscious bias will impact my career, the majority, again, answer in the affirmative, that they are concerned that unconscious bias is going to impact their career in some way. We didn't specifically ask them how, because we only asked one open-ended question, but I think that it's important to note that despite having this education, this self-reported education, those in training are very concerned, preoccupied that unconscious bias will impact their career in some way. One of the most important ways to address unconscious bias is to actually address that unconscious bias in the moment, which means that you should feel comfortable discussing unconscious bias with your colleague. So what we see here is how, on the Likert scale, how comfortable the respondents were discussing unconscious bias with a colleague out of all respondents. And again, the majority here actually responded in the negative, that they were either neutral or disagreed or strongly disagreed, that they felt comfortable discussing unconscious bias with a colleague, which is, again, very interesting. Not surprising for those in independent practice because they don't have the education or potentially the toolbox and the toolkit to really address those feelings, but concerning that even those early in their careers who report that they are getting education, who report that they are concerned this is going to impact their career, don't feel comfortable discussing this with a colleague. All of that is a lot of data. I recognize that. we looked at it and came up with some recommendations as a group as to what we think would be the next few steps for the Unconscious Bias in Medicine Task Force. So the things that we noted, the first thing we noted was that there's a difference between education on unconscious bias between those in training and independent providers. Not unexpected. There was a need, therefore, to look at curricula. And as the AAMC and the ACGME are promoting this, it's not surprising that medical education and culture in medical education is shifting or growing, to be totally honest, to include more psychosocial elements alongside traditional pathophysiology, traditional human anatomy, and pharmacology. The aspect of the psychosocial care for the whole patient is evolving. Not that it wasn't important before. Trust me, I was an old curriculum medical student, but it looks like there's a shift that's happening, which is really exciting. Both those in training and those in independent practice reported experiencing unconscious bias currently, either within their education or within their clinical practice. So this is, again, coming from the respondent. Like, I feel like I have experienced unconscious bias, me. Not necessarily, again, that it impacts the clinical care, which independent providers admitted, but that our colleagues, our cohort are feeling, our future in medicine is feeling this pressure. They feel like they've experienced it. It is unclear how independent providers are reporting that unconscious bias has affected them and affected their clinical decision-making. We did not ask the how. That is a problem with a Likert scale study and a survey-based project in general. We don't know the how, we just know the is. This is what we found. It does suggest that independent providers will know it when they see it, despite the lack of education that they self-report. But the other important takeaway, I think, that's really important, both as a medical educator, both as someone who's early in my career, is that our future, the people who are going to be taking care of me, they report that they report that they're getting education, but they're still worried about how it's going to impact their career. So the preoccupation might be warranted if you really think about it at a granular level, because those that are going to be making decisions about hiring, about mentoring, about helping the next generation don't report the same level of education on the topic as they do. So what are you going to do about it? What's really important, and I think what's going to be the next big task for the task force, is think about the how. How is the unconscious bias impacting your clinical care? You said it was. Now the next question is how. And that how should be both from a provider standpoint, but also a patient standpoint, especially because we need to understand if the patient is perceiving a difference in their clinical care based on unconscious bias, based on characteristics, based on race, and not based on the population health, the factual information that we can gather. We know that independent providers feel as though they're not getting, or they didn't receive good education on unconscious bias. People are uncomfortable talking about unconscious bias. So the idea of developing toolkits and safe spaces to have difficult conversations are a must. And I think that is a niche that we can fill with our colleagues. And here's the radical thought that we thought. Think about the way that medical education is currently delivered. The model has the preclinical years where you're in a classroom, you're learning, you're doing workshops, you're doing seminars, and in an era of COVID, you're doing webinars on topics such as unconscious bias. That's happening right now. Whereas those in independent practice, we were not exposed to the same level of education that our future is having. And I'm not saying to tear down that hierarchy in medicine about education. It exists for a reason. Safety, learning, apprenticeship, that art and style of medicine is still very, very important. But I think that what we all agree on is that what's most important, especially for delivery of patient care, is learning from the expert in the room. And learning from the expert may mean having this hands up, hands down, bi-directional conversation with those in training and those in independent practice surrounding this psychosocial aspect of medicine. I'm not expecting a medical student to know how to insert a chest tube, but I think that they might be able to teach me a little bit more about unconscious bias. And in that negotiation, I'm happy to help them insert their first chest tube, see one, do one, teach one. So, next steps. I hope everyone was able to get outside and enjoy the beautiful weather today. And I wish that I had a daytime photo that I just took today because it was so beautiful. But this is DC, this is our home, these are our patients. The next steps are going to be focused on them and how can we be better for them. That's our role, that's our obligation to patients. So just reiterating some of the stuff that we've talked about. More research, it needs to happen. This is a very open field. The Medical Society of DC is on the forefront of this. Not many other states or metropolitan governances are looking at this as a topic. Toolkits are going to be very important. We need to help facilitate knowledge, understanding, and addressing unconscious bias. And we really need to talk about the how. How is this impacting our patients? So, education, I keep saying over and over and over again, and you probably tuned me out at that point, but it is the crux of all of this. So what should be our meat and potatoes? What should we really be using as the guide for what topics need to be addressed? Unconscious bias regarding what? Where's our biggest bang for our buck? So remember that the task force very pointedly had an open-ended discussion question at the end of our survey, asking what the experience was that providers were having regarding unconscious bias. We did a nice qualitative data analysis of all of those responses. And there were many open-ended responses, some longer than others. Both of those clinical cases that happened that I brought up right at the very beginning were based off of the qualitative analysis that we were given. We analyzed this with a narrative framework for qualitative data analysis. We did want to approach it systematically. And basically what we did was members of the task force compiled some themes and we put them all together. And I'm a visual person. I'm an emergency provider, so I have ADHD. And I made word clouds because I like looking at pictures. So for those of you who are unfamiliar with word clouds, the larger the word or words, the more often they appeared in the thematic responses. So this is from the student open-ended responses, where they had themes basically of race, ethnicity, sex, and gender. They pointed out a couple of cases where they were concerned about their own socioeconomic status or the socioeconomic status of a patient encounter. also the language was also something that, spoken language was something that was very important, that came up a few times, but not nearly as strongly as race, ethnicity, sex, and gender. This was very similar to those in training. So this is separated from medical student and those in GME programs that responded. Again, race and ethnicity were very common. Sex and gender were also the most common things. Nationality and language spoken, again, presented itself. What the trainees were also interestingly reported is that there were elements of faith and spirituality that were also included in their experiences with unconscious bias. And independent providers had a lot to say. You'll notice that race, ethnicity, sex, gender, and language are all there. Independent providers interestingly spoke a lot about ageism, and it was bidirectional. Some folks said that they felt that, you know, they were biased against for being too old. Some people felt that they were being biased against for being too young, and that came up in conversations that they'd either had with patients or colleagues. Practice environment was also something that popped up. And that theme was focused a little bit more on, a lot of cases came, not surprisingly, from the emergency department, where there's high stress, high stakes, high volume of patients, and that's where unconscious bias will really rear its ugly head. Sorry. So in summary, this is the take-home points, guys. This is the meat and potatoes. Thanks for bearing with me. We all have biases that we don't know we have, and these are unconscious bias. They do not make us bad people. They happen, and we can address them. It's how we address them that's the most important thing. In Washington, D.C., our home, our backyard, we know that those in training are receiving education. Those in independent practice are not receiving the same education. Everybody has reported experiencing unconscious bias. And our next step should really include exploring and education, providing toolkits for providers, and to explore a little bit more of the how. If we're able to explore a little bit more of the how and provide toolkits at the same time, what's most important from that qualitative analysis is going to be the concepts of sex, gender, and race and ethnicity across the spectrum of provider and across the spectrum of the career of a clinician. Those were the consistently most important things and most common things that people reported experiencing. And with a summary and with about 50 minutes of your time and night, I thank you all. And I'd love to open it up for some questions, comments from this really seasoned group.
All right. So first question, and this is something going to the basics. Can you talk a little bit about the student population that answered the survey and any reflections on that?
The student population that answered the survey was mostly women again. It killed me because the majority of them were born in the 90s. They were a little bit young, not younger, but clearly younger than me, old enough to be in med school. The majority, so we asked the zip code of their primary school or address, and I will say the majority of them came from one zip code. I cannot promise you that I know which institution is in that zip code. I'm relatively new to the area. And again, the majority were white. So I think that is a very important question. And that's also a very important lens to look at all of the experiences and all of the open-ended questions, right? Like we can only talk about the population that responded to our survey, and they seem to be cisgendered white women who identify as heterosexual. And actually they were also in their first 1 to 2 years of clinical education. So they were in their undergraduate medical education. So they were in their preclinical years.
Great. And any reflections about if the task force noticed a difference between respondents from Georgetown Medical School, Howard University Medical School, well, especially Howard University Medical School or GW?
We did not look directly at that, but that's a wonderful point to put. I will say that out of the 100 or so respondents, I want to say about 70 to 80 of them were in the same zip code. So it would be really hard to really do a good rich analysis between the medical schools themselves. We also felt very strongly that we wanted this to be anonymous. And we wanted the medical students to know that their reporting on their education was not going to come back to the specific institution. We looked at it a little bit more as the broadened idea. I think that for the, especially for the bright young docs, I know that there are some really interested medical students in this type of work. And so I think that looking at it specifically from an undergraduate medical education lens is going to be really important. I know that a member of our task force is actually involved with medical education and underrepresented minorities in medicine at Georgetown University School of Medicine, working on a program to help increase diversity and help with inclusion. And so I'd be really interested to see if we can't leverage this result to say, hey, well, maybe our next step should also be to look across the medical student population and hopefully in theory, we could provide a strong curriculum for medical schools within the district and then countrywide.
Great. Another question about the results of the survey. What are the next steps with the survey data? When will it be published? When will it be made available, et cetera? Do you have any comments on the next steps for the survey data itself?
So as with all things, the task force is large, but we're compiling everything to put together basically a publication, but it needs to undergo comments and reviews from the task force itself before we seek publication for it. Personally, I would like to do a little bit more strong statistical analysis, which just requires a little bit of my plate to get a little bit less full at the moment. But I think that in the next month or so that'll happen, just to make a good, strong statistical analysis before we present it for publication in a larger journal. But it will happen, I promise.
All right, we've gotten some plaudits for the presentation. We also had a comment about, and I'll say because Dr. Lawson posted in the chat about several physicians, several of us have had funded research examining unconscious bias on patient care. How do you recommend physicians like Dr. Lawson and others who have done research in this area get in touch with you or the task force, and how can they work with the task force or you work with them?
Wow, how perfect. I would love to hear about those projects myself. Like I said earlier, and for those of you who kind of trickled in over the course of the presentation, my academic interest is the intersection of health policy and health disparities. Specifically, I'm very interested in LGBTQIA health as a member of that community myself, and how we can do better, especially in the emergency department, for that care. I think that there is an opportunity here for rich collaboration between academic institutions, and also there's a role for the Medical Society of DC here to be the home of all these great clinician minds to sit down in a room and talk about those projects. I want to hear about those results. I'm not going to steal them, I promise. Academic integrity is really important, but I think that at the end, our goals are all aligned to do better for our patients, regardless of if you're a resident and end up practicing in North Dakota or Alaska, or you hopefully stay here in DC for the long haul and really help deliver quality patient care. If you're interested in getting in touch with me, I'm happy. You see my email there, matt.lecuyer.md@gmail.com. Robert also can very easily get in touch with me, as can Pia. All of our emails are listed here. The next steps for the task force, I think, are really exciting. We're going to have to really think about our next set of goals and objectives, and if that's going to be either changing our name to the task force for tackling unconscious bias in DC, I think that's going to be really exciting too. But if you have any other comments or want collaboration or anything, please feel free to email me at that listed email address. Again, hey@msdc.org is probably a much easier email address to remember and write down, but Robert knows how to get in touch with me.
All right, I think at this point, let's do a last call for questions, because I believe that's it in the queue. So if you have any other last questions, get them in now. I do see one other question I may have missed. Can you talk a little about the definition of independent practitioner? What kind of person do you think was represented in independent practitioner?
So from what I can gather, the independent practitioners, the reason why I kept saying that was that DC is actually a municipality and the surrounding area, DMV, with independent practice for PAs and NPs. And when we designed the survey, our thought was also very much to look at the patient experience. And it's important for patients and for us to really encompass all of independent providers, not just physicians, but really because of the independent practice rules, we felt like it was very important for us to include both physician assistants and nurse practitioners within our independent provider cohort. The majority of people who responded were physicians in hospital-based or academic practice, I won't lie. But we did get a smattering of physician assistants and a couple of nurse practitioners. But because we included everybody who could independently practice, that's why we keep referring to those in independent practice, just for full disclosure. I really want to say thank you to everybody for coming tonight. Personally, for me, this has been a labor of love. I couldn't have been more excited when Dr. Pineda approached me to ask me to chair this task force. I know it's interesting to have a presentation on unconscious bias affecting underrepresented minorities given to you by a white cisgendered male. But I think it's really important to know that I am an ally to that community and to communities of underrepresented in medicine. Depending on how you define it, I feel as a member of the LGBTQIA community, I fit that mold too. But what's most important, and I hope I am exemplifying, is that people who look like me want to be having these conversations, and we want to learn, and it is all about patient care and patient care delivery in a world where we can really promote health and wellness across the board. So I hope that I will use my cisgendered white male privilege to really help amplify the voice and help impact positively medicine in the district. Sorry, that was a little bit emotional for me, but I think it's important.
Well, I'll take this opportunity to thank you again and the entire task force for pulling together such wonderful data. Thank you to everybody for participating. Please stay involved as you see the slide in front of you with contact information. Feel free to contact any of the three of us to share your thoughts, share your information, learn more, and so forth. So thank you all for attending. We hope to see you and plan to see you at an upcoming Washington Healthcare on Wednesday webinar. Have a great night, everyone. Thank you.
Thank you, everybody. Good night. Stay safe and healthy.